Hello again. We're back with Dr. Ash Gupta and we're going to be talking about neck and upper limb blocks. So what is the anatomy behind the interscalene block?
Right, interscalene block is basically the muscles, the scalene muscles where the nerves come out. So brachial plexus has C5, C6, C7, C8, and T1 nerve roots. The C5 and C6 are the upper trunk, which comes between the scalene muscles, anterior and the medial scalenus, which is where we target for the interscalene block. And now, as you can see in the slides, it also has some dermatomes, myotomes, and osteotomes. So in terms of, so essentially how you do the block, you basically go between the two muscles and look for the traffic light sign, as you can see in slide, and you aim for the local to targeting the C5, C6, that upper trunk, which is, we get the local around it.
So for which surgeries would you use this interscalene block?
So interscalene block is most commonly used for shoulder surgeries, which could be open or arthroscopic surgeries. Other common indication is for humeral surgeries, for proximal humerus fracture, and also some lateral side of the clavicle surgeries where it can be useful.
Okay, so whilst you're doing the block, what is the end point of the actual injection?
That's a good question. So essentially, as I mentioned, what you're aiming is to get the needle around the upper trunk and inject the local, because you enter from the posterior side, so obviously your first spread of local is around the posterior of the trunk. Ideally, you would want to have anterior spread as well. So personally, if I'm doing it for analgesic block, I'm reasonably happy to have a posterior spread as well. But if I'm doing for awake, I would like to have an anterior spread as well. So I would like to have a nice circumferential spread around the whole upper trunk. That would be my endpoint for awake surgery.
So what the block itself, the area is quite heavy. It's quite dense in vessels and other neural structures. What tends to be the complications for this block?
Yeah, I mean, depending of how you do it, there are some common complications, or you can call them side effect, which happens. As I tell my patients, as I'm injecting the local will spread to certain nerves, depending on the volume I inject. So common thing which you can get is a bit of hoarseness of voice, which is a block because of blockage of the recurrent laryngeal nerve. Other thing which can happen, as I do tell the patient, is the Horner syndrome, which is because of the sympathetic chain which is blocked, which results in sort of meiosis, like dropping of the lid, eyelid, and the redness on the face. Another common thing which will happen pretty much in all the patients we do a interscalene block is the phrenic nerve palsy on that side, which means that the breathing will be different in patients, and I do warn them that after the block you will have a bit of a different in breathing, so maybe you'll be aware of your breathing. So just to be aware that this is the problem of the block, and it will wear off as block wears off.
So you just talked about the phrenic nerve. How do we avoid blocking this?
Yeah, that's a good question again. Now, phrenic nerve, as you can see on the slide, it lies over the anterior scalenus muscle. So you can make an effort to avoid putting local there. Having said that, if we are doing a proper interscalene block with even more than 5 to 10 mils, you would probably block the phrenic nerve. So if you want to avoid a phrenic nerve block, you have to not do an interscalene block. So there is something known as upper trunk block, which can minimize the risk. So essentially, when I say upper trunk, is you come down on the interscalene, somewhere between the supraclavicular and interscalene, where you can see a suprascapular nerve coming out. At that point, you can do upper trunk block. If you want to be absolutely sure to avoid a phrenic nerve, you have to do a separate suprascapular nerve block and avoid doing any interscalene block. That's the only way you can block. You can avoid giving a phrenic nerve block.
Okay, that's good to know. Moving on next to the supraclavicular block, what tends to be different from that and the interscalene block?
As you can see on the slide, the pro position is now much lower in the neck. It is still over the clavicle or behind the clavicle. And the difference in the approach is there we are looking to block all the three trunks rather than the upper trunk, which is selectively done for interscalene. Supraclavicular block, we are doing all the three trunks. So upper, middle, and the lower trunk is being targeted and blocked in a supraclavicular block.
Okay, and what about the axillary block? So what is that, and what common indications to doing those blocks?
Yeah. So axillary block, as you can see in the slide there, it's done in the axilla, as the name suggests. And at this point, we are targeting the distal nerves of the brachial plexus. So in order of sort of appearance, so musculocutaneous nerve, median nerve, ulnar nerve, and the radial nerve. So we are targeting these four nerves separately. Now, the musculocutaneous nerve is probably a little bit away from the plexus, whereas the other three nerves all around the artery, so reasonably easy to block them. But musculocutaneous nerve is something which you need to look for separately to block it.
And given that there's so many nerves, what is the sequence of blocking these nerves?
Now, you would see the video. So essentially, you need to get the radial nerve first, because it is a big nerve and it can take a while to actually get blocked. So my target would be to keep the screen with the left side of the screen as the biceps. So I approach from the left side of the screen. We go over the under the conjoint tendon, under the artery, and the needle is targeted over the conjoint tendon where the radial nerve is. And once it's done, I come back and go over the artery to get the median nerve, then followed by that the ulnar nerve. And as we are coming out, we can do the musculocutaneous nerve separately between the biceps and the coracobrachialis.
Okay, perfect. Thank you very much.
Thank you.